Greetings, certified partner trauma therapists. My name is Dr. Stephanie Carnes. I am the president of IITAP, and I will be one of your faculty members for Module 2 of the CPTT training. My background is in clinical sexology and also marriage and family therapy. And at IITAP, our mission is basically to help sex addicts get compassionate and effective treatment, and their partners and their families. And that's what ITAP is all about. So we really welcome you to the community. We're so excited that you decided to join. Today, what we're going to be covering is basically an overview of treatment for the addict. So we're going to be talking about the criteria for sex addiction, diagnosis, also a general overview of treatment and some of the different resources available and the 30 task model of treatment. And so you will get a general platform or a general understanding of what CSATs learn in the Certified Sex Addiction Therapist training. The reason why we're doing this video today is that because we didn't want to take a lot of time away from our time together where we want to focus mainly on partner-related issues. So that's why we're going to have this video be a prerequisite for you to watch prior to Module 2. So thank you for joining me today. So I am going to go ahead and jump in. One of the things that you may be aware of is there's been a lot of controversy in the field about whether compulsive sexual behavior is an addiction, is a real disorder. There's a lot of misinformation out there about that. And so we are going to take a little bit of time at the very beginning of CPTT to talk about just the status of the field and some of the new developments that have been occurring. So as you may be aware, there is still a lot of controversy around compulsive and addictive sexual behavior. You'll see a lot of information or misinformation in the media, things like sex addiction is not a real disorder, there's no diagnosis for sex addiction. And so, and there is not a DSM diagnosis for sex addiction, which has left the field with a lot of confusion about what are we going to call this, and has really put us behind in terms of research and developing as a field of treatment. It's our opinion at ITAP that this is a very real condition, and we take a similar position as the World Health Organization and the American Society of Addiction Medicine in our belief that this is a very credible, legitimate illness that deserves treatment and acknowledgement. So I'm just going to kind of back up and talk a little bit about historically how this controversy came to be. One thing that a lot of people don't realize is the DSM-3R did contain a category called non-paraphilic sexual addiction at one point. And there was a lot of controversy around that diagnosis being in the DSM. One of the biggest concerns that people had was that it would be used to get sex offenders off the hook in court cases. So it would be misused forensically to get a reduced sentence, that type of thing. And so it was removed. And since then, the field has kind of been left bereft of a diagnosis, and really kind of arguing over what is the best terminology for this disorder. And so if you look to the literature, the most common terms that we see are sexually compulsive behavior, sexually addictive behavior. Some people have looked at it as an impulse control disorder, and others have said, well, what if we called it like hypersexual behavior disorder? And there was a really big push to get this into the DSM-5 recently under the label of hypersexual behavior disorder. And unfortunately, that was not successful. Now, if you look at the different ways that the disorder is conceptualized among these different, using these different labels, there's a tremendous amount of agreement on the constellation of symptoms that have to be present to qualify for the diagnosis. So there's tremendous just agreement in the field on the signs, symptoms, and behaviors associated with compulsive sexual behavior or sex addiction. And so really there's really good consensus on the criteria. So even though that is the case, the DSM-5 did not put hypersexual behavior disorder into the DSM back in 2012, unfortunately. Um, but we did have a big breakthrough this past summer when the World Health Organization decided that they were going to include compulsive sexual behavior in the impulse control disorder section of the ICD-11, which is the International Classification of Diseases. Now, that is the classification system most physicians use, but therapists are allowed to use that for diagnostic purposes. So the World Health Organization decided to take a relatively conservative position and put it in impulse control disorders now, but basically what they released in a statement was that there's still a lot of evidence that it could be a behavioral addiction, and so as more research comes in, ultimately they will decide what category to put it under. Now, interestingly enough, that is the same course that gambling took. So gambling initially was categorized as an impulse control disorder as well and was later moved. So it will remain to be seen ultimately how it will be categorized. But for now, it is categorized in the impulse control disorder section of the ICD-11. So you can see here, this is the ICD-11 and the C6C72 is the category compulsive sexual behavior disorder. So that is one of the categories we can use for diagnosis. And we're going to come back to the issue of diagnosis. But next, what we're going to do is we're going to look at compulsive sexual behavior or sex addiction and the different criteria that we use in the CSAT training, which again is very similar to the criteria conceptualized by many different theorists on this issue. So here's just a lay definition for sex addiction. It's a pathological relationship to a mood-altering experience that's sexual in nature that individuals continue to engage in despite adverse consequences. And we use 10 criteria for addiction. And if people meet 3 or more of these, then their behavior would be considered problematic. So I'm going to go ahead and go through each of the criteria one at a time. And today what I'm going to do is I'm going to share some art therapy drawings of some of my clients to kind of illustrate some of the principles that we're talking about and bring them to life a little bit for you today. So the first criteria is a loss of control. So the client experiences clear behavior in which they do more than they intend to or they want to. So this was a female client that I had. You can see the line in the middle of the drawing. The top half of the drawing is the part of herself that she shows people. The bottom of the drawing is the part of herself that she doesn't show people. So she had been in recovery, went to chemical dependency treatment 3 times and eating disorder treatment once, and was very open about her struggles with chemical dependency. However, what she was keeping secret was her secret sexual life, in which this was at the time when Craigslist was very popular. She was going to hotels and having anonymous hookups with random men. And one of the things that she was participating in, she had a very extensive trauma history in which she experienced a lot of physical battery, and she was doing a lot of pain exchange within that acting out. And so she was actually taking some pretty high risks in her addiction, and it got pretty out of control over time. And this client here was an addict. He was a married man and was engaging again in anonymous hookups with both genders on the side. spun a real wicked web of lies in his life to hide his behavior. And this is one of the things that we really try to do when treating the addicts. We want to disable that secret double life, help them get honest and live a congruent, transparent public and private life so that they can, reduce shame and be in a much better place. Oftentimes, having a big secret life is very distressing for our addicts, and when they are able to let go of that, they feel a very big sense of relief. We also see that the behavior is compulsive. And when we see a compulsive pattern of behavior, it's out of control behavior over time that's used to reduce anxiety and self-medicate negative feelings. Okay, so this drawing is a really good illustration of that criteria. This is one of our porn addicts. He says, life sucks, and so what am I going to do but self-medicate with porn? So that's a very common dynamic with our pornography addicts. And this here is one of the female patients I worked with. So you can see here on the inside, what she's showing is the inside of herself versus the outside. On the inside of herself, you see her father, who was very critical and emotionally abusive, telling her, you're so stupid, you're so worthless. And she's internalizing that, feeling anger, self-pity, resentment, sad, disgust, self-loathing, all of those feelings. And what does she do on the outside? She has her finger up, her middle finger up, a joint in one hand, and all the men around her saying, you're beautiful, you're amazing, so sexy, damn girl. And so you can see she's medicating that negative internal state through her sexual behaviors. This next drawing is also, this is a pornography addict. He's also using alcohol and cocaine, as you can see in the drawing. It says, broken dreams, no friends, no future, death, shame on you, and the devil says, I won you, bastard. So you can see from the drawing, obviously this is a behavior that has gotten out of control over time. The next criteria that we use is that there's efforts to stop the behavior, repeated specific attempts to stop the behavior which fail. So this client was a workaholic sex addict. Now he traveled for work and had relationships in different cities, would also use a lot of pornography and prostitution. And what ended up happening is over time he ended up developing a significant relationship in another city that ended up having a family. And so he had two families that didn't know about each other and was going back and forth. So you can see there in the drawing, the suitcase, the broken heart, the pharmaceuticals, the alcohol, and he's cracking himself up beside the head, full of anger and self-criticism in regards to his behavior. Now, this next client here is depicting the lack of tools to be able to stop the behavior. One of the things that happened for him, this was a physician, and he was struggling with compulsive masturbation. And for him, it got to the point of masturbating like 8 or 9 times a day, and it was like between office visits, he was having to stop to basically medicate and reduce anxiety through compulsive masturbation. So unfortunately, what happened for him, he went to a 12-step meeting, and there was a lot of acting out in the group, and he ended up hooking up with some of the other group members. And then he went to a sex therapist at one point who told him, masturbation is healthy. You can't masturbate too much, which I agree that masturbation is healthy. However, it can become compulsive, as was the case for this gentleman. And so he didn't get any help or wasn't able to get any traction in his recovery until he got to treatment. So here he's depicting the lack of tools to be able to stop his behavior. And this client here is just depicting his head in a vice, with the difficulty of not being able to stop his behavior. You also see that there's a loss of time, significant amounts of time lost doing and or recovering from the behavior. So this client just depicted addict time and real time, like they're going by at different speeds. And this client here is a pornography addict. He's also using some other substances, and you can see he would spend hours on pornography. You can see there is the grandfather clock scowling at him because of the hours spent. The next criteria is preoccupation, obsessing about or because of the behavior. So this was a married client that was having 2 affairs on the side. And it's a good example. Here he is at his desk at work, and he can't focus on work because he's preoccupied with the affairs he's having. And this client here is depicting his preoccupation. He's got his multiple addictions floating around in his mind, which is food, marijuana, alcohol, women's body parts, pornography, all floating in his mind. Next, we see an inability to fulfill obligations. The behavior interferes with work, school, family, and friends. So this client was a priest that came into treatment. On the one side, you could see the sunshine, the love, the church, all of that. On the other side, you see his porn and prostitution addiction. He's depicting himself as split in half. From a clinical standpoint, we use the term compartmentalization for that. When you have that secret double life that's very separate from your other life, we say that the client is compartmentalized. We see this often with our patients with severe trauma. We also have continuation despite consequences, failure to stop the behavior because of it, even though you have problems such as social, legal, financial, physical, health problems, or work problems. So this was a female client. You can see her husband up in the corner walking out the door saying, "I'm done," and the children saying, "Mom needs help." And she's laying in bed while one man brings her vodka, the next one brings her pills, the next one brings her food. And there's the toilet is next to her because she's also bulimic. So you can see the interaction there with her chemical addiction, her food addiction, and her sex addiction all together. And this client here was an alcoholic prostitute user. He actually received 2 DUIs and was picked up for solicitation of a prostitute and was having significant legal consequences as a result of his addiction. We also see an escalation, need to make the behavior more intense, more frequent, or more risky. So this client here is depicting his escalation. You see the client there on the top corner of the cliff, about ready to fall off the cliff. And this client here is depicting his escalation. He was also using crack, and so his crack pipe is pumping up his sex addiction like a bicycle pump. The next criteria is losses, losing, limiting, or sacrificing valued parts of life such as hobbies, family, relationships, and work. So this is one of our female clients. You can see, unfortunately, her 3 children were removed from the home during her addiction. You can see here as she hangs herself on the tree of strip clubs and men and S&M and crack and cocaine and porn and heroin. Now the happy end of the story there is that she did get her children back after a year of recovery, so there's a positive outcome with that client. The next one is withdrawal. Stopping the behavior causes considerable distress, anxiety, restlessness, irritability, or physical discomfort. So this is one of our female clients. You've got when she has access to the salads and the Diet Cokes and the pizza and the alcohol, where she was binging and restricting with food and drinking, she sees herself in the sexy red dress and would act out in her sex addiction. And when she doesn't have access to that, she sees herself in a coffin. And this client here is depicting feelings of withdrawal from porn addiction. He's chained to his keyboard. So when we're talking about how do we actually diagnose sex addiction, the appropriate categories are for the DSM. We recommend either other specified sexual dysfunction, F52.8, or the recommended ICD-11 code that we spoke about earlier. Now, there may be times when another diagnostic category might fit for your client, such as they may also have an anxiety disorder or PTSD or substance disorder, ADHD, and oftentimes you may have better luck with insurance companies if you're working with insurance to use one of the other categories that they meet the criteria for. So in addition to this, in order to get insurance reimbursement. So sometimes clinicians can get a little creative with diagnosis here. The most common possibilities are other specified sexual dysfunction, other specified disruptive impulse control and conduct disorders, unspecified paraphilic disorder. Also, occasionally, OCD might fit for the client. So those are some of our more common DSM-5 possibilities. Now, if we're looking at differential diagnosis, there's a lot of things to consider because there are so many disorders that are comorbid with sex addiction. So the personality disorders, we have very high rates. About 17% of sex addicts have personality disorders. The most common are antisocial and narcissistic. So that's certainly a consideration and has very significant treatment implications, of course. The paraphilias. Now, we will be talking very briefly about the controversy at the beginning of the CPTT Mod 2 and sort of the status of the field. And I will talk to you a little bit more about differentiating between sex offending paraphilias and sexual harassment. So we will talk a little bit about that during the training, just briefly at the beginning. But for a paraphilia, paraphilias are things like exhibitionism, voyeurism, fetishism, sadomasochism, pedophilia, of course. There are 9 paraphilias in the DSM. Now, in order to meet the diagnosis for a paraphilia, it has to cause significant distress or distress of unwilling persons or those not of legal age. And so there is an overlap between sex addiction and paraphilias that is important to consider. So, and treatment looks very different for a paraphilia than for sex addiction. So it's important to keep that in mind. ADHD is one of our most common co-occurring illnesses, especially with our young porn addicts and our gaming porn addicts. It's very, very common. Also, mood and anxiety disorders are very common, especially bipolar disorder, post-traumatic stress disorder, substance use disorders, obsessive compulsive disorders. And one of the things that we always want to rule out is cognitive or organic conditions, things like traumatic brain injury or a stroke. Sometimes one of the common neurobehavioral sequelae to brain injury and stroke is inappropriate sexual behavior. So it's important to look at time of onset and when the illness started, because if it's due to TBI or stroke, they may not respond as well to traditional addiction treatment methods. And you may want to go to a neurobehavioral psychologist to get treatment. So many different differential diagnosis possibilities. One of the things I always want to emphasize to our new members is that we want to be careful not to overdiagnose our clients. That's one of the criticisms of people working in this field, is that we're very quick to apply the label of sex addiction or compulsive sexual behavior, and that we have a lot of false positives. And I think that's important to keep in mind. So what I would say about that is, just because someone has had affairs, used prostitutes, attended a strip club, used porn recreationally, does not mean that they're a sex addict. It's just as important to determine who is not a sex addict as it is to determine who is. So let's take affairs, for example. There's lots of reasons people have affairs, and it doesn't necessarily mean that that's a sex addiction. So how we delineate whether it is again, we go back to the criteria and look, do they really qualify for this diagnosis? And we use also testing, comprehensive testing. As we go along, we're going to take a good look at some of the tests that CSATs use to determine whether somebody meets criteria or not. So one of the things that we want to keep in mind is when somebody comes in for treatment and they present sexual issues, we have to do a very comprehensive assessment process. And so that involves, for CSATs, that involves a significant amount of testing. That also involves a very comprehensive sexual history. And then we want to look at, is this a situation, or is this a pattern of behavior? So if it is a pattern of behavior, then we can determine, is this pattern due to a mental health issue, such as a mood disorder, like mania, for example, and bipolar disorder, or a personality disorder, for example, or due to a substance use disorder? Or is their behavior compulsive and we're seeing repetitive cycles, efforts to stop, and it's resulting in life problems? If that's the case, then we're looking at treatment for compulsive sexual behavior. And to determine whether they should go inpatient or outpatient, typically the things that we look at is if the patient is suicidal. That's one of the things we really have to pay attention to with our patient population. We have high rates of suicidality. And so it's really something that we have to pay attention to. So if they're suicidal, they can't stop no matter how hard they try, and they're a risk to self or others, that would be a great inpatient referral. Now, if they're outpatient, if they can commit to therapy, they have the supportive family, and they're able to maintain periods of abstinence, that's a better outpatient case. So those are some things to think about when looking at level of care. So as we're talking about differential diagnosis, there's so many different things to consider. For example, a lot of people, sex versus porn addiction. A lot of people are looking at porn addiction as very different from sex addiction. In many ways, treatment is very different. It, focuses more on safe use of technology and device monitoring, social support, and decreasing social isolation, and managing triggers. That's very, very important in porn treatment. And oftentimes you have less complications from a family therapy perspective because the partners, because the addicts haven't crossed the flesh line, so to speak. The partners tend to be a little bit more supportive in the treatment process in general. And the betrayal trauma tends to not be as severe as when the sex addiction involved a lot of acting out with other partners. And also, one of the differences we see too is with sex addiction, we tend to typically see a very significant amount of trauma. With porn addiction, that varies. You have clients that have a lot of trauma, and you have some clients that really don't have a lot of trauma. So there are significant differences in treating those populations. Another thing to look at when people are acting out sexually, how does this tie back into their trauma? Is this a trauma reenactment as opposed to an addiction? Paraphilias and fetishes, as we mentioned before, is this, we can clearly see that fetishes aren't addictions, but they do coincide at pretty high rates with compulsive sexual behavior. So what do they need in terms of their treatment of their fetish behavior versus their addiction? And sometimes those can be very different treatment recommendations. Another thing to consider is, what about erotic minorities, for example, like polyamory? Polyamory is not necessarily sex addiction. And so we want to be careful not to, again, globally pathologize or give a diagnosis when it's not warranted. So we have to look at that distinction. Another thing to take a look at too is moral incongruence, and how does that fit in with their behavior. So with moral incongruence, you have behavior that is very incongruent with the client's values and morals. So for example, you might have somebody that comes in and is very distressed around their pornography use. They maybe use pornography like once a month, or they've used it a small handful of times, and they might believe that they're a porn addict when actually they may not meet the criteria. So we have to, again, be careful not to over pathologize there. When you have a personality on board too, personality disorder, that can look very much like, for example, narcissistic and antisocial personalities can look very entitled, domineering, self-interested, have a lack of shame around their sexual behavior. And it might be more about their personality disorder than really an addiction. Another thing to keep in mind is sex offending versus sex addiction. Now, different states have different laws around treating sex offenders, but there are many states that you have to be a licensed sex offender treatment provider in order to treat sex offenders. And so there's not only a scope of practice issue there, but you want to be careful. And there are some sex offenders that are sex addicts, and there are many who aren't. The majority of sex offenders are not sex addicts, is what research shows. So, that's another important distinction. What about a mood disorder? Could it be a mood disorder versus sex addiction? So when we are assessing new clients, there's a lot to tease out. The evaluation and assessment process takes time. And that's an important thing for those of you that are partner specialists to realize, is that assessment and evaluation can take weeks. And so we want that process to be thorough. We want them to get their testing all done so that the addict therapist can really get a good handle on what's going on. So yes, there are different models and etiologies to explain and treat compulsive sexual behavior. We can look at it from an addiction framework. We can look at it from as an attachment disorder. And there's some very compelling videos and books that talk about addiction as an attachment disorder. We actually spend a fair amount of time in CSAT, in the CSAT training, talking about addiction as an attachment disorder. Also, trauma reenactment. How does their trauma history play into their current behaviors? And that is an important, really important component of the treatment process, is to look at that underlying trauma history there. Another thing to consider is, could this be due to early exposure to pornography or sexual behaviors that developed over time? Could this be a learning process or about sexual conditioning? So for example, Mark Lewis has a very profound body of literature supporting addiction as disordered learning. And we learn from our behaviors, we learn from our rewards, and we're conditioned sexually around our behavior. So we can look at it from that lens. We can also look at it from a psychodynamic perspective and a sex therapy lens. It's really important to have some background if you're working in this field in sex therapy and to have a very comprehensive overview of sexual health and what that means and sexual dysfunctions and treatment of things like paraphilias, which as I mentioned earlier, is different than compulsive sexual behavior disorder treatment. So next we're going to talk just a little bit about prevalence and etiology. Many of the studies that have been out there have estimated prevalence rates to be at about 4.5%. However, just recently, just this last summer, there was a study that came out that was one of the first U.S. nationally representative samples looking at this issue, and the rates were higher than anticipated. So, for example, in this study, it looked at clinically relevant levels of distress and or impairment associated with difficulty controlling sexual feelings, urges, and behaviors, and found about 10% of men and 7% of women endorsed that. And so it was quite a surprise, and it really made the media, especially the women's rates would be so high. And so we have a condition here that is probably being vastly undertreated, and there's a lot more people suffering and still a lot of stigma around sex addiction as a diagnosis. So it just goes to show how important it is for us to educate, get the word out that this is a legitimate condition, because there's a lot more people out there suffering than we initially thought. So we're going to talk just a little bit about etiology, where sex addiction comes from, give it just a general overview of some of the research that's going on right now in the field, and then we're going to get back into talking about treatment. So first we're going to talk about trauma and abuse, then we're going to talk about neuroscience, and then we're going to talk about family dynamics and attachment.